Hey, future nurses, get ready because today we are diving deep into chest trauma. We've got a whole stack of your go-to resources right here, articles and case studies and research, and we are pulling out the need-to-know info you'll need to ace those clinical rotations.
That's right. You'll be hitting those hospital floors prepped and ready, not just to recognize chest trauma, but to understand the why behind it.
All right, so let's unpack this.
Let's do it.
When we talk chest trauma, we're talking some serious forces at play.
Right.
We've got blunt trauma, so think car accidents, falls.
Uh-huh.
Someone takes a tumble down the stairs.
Yep.
And then on the flip side, we've got penetrating trauma.
Yeah. So that would be like gunshot wounds, stabbings, those situations where something pierces the chest wall.
Right, and now you might be thinking, okay, trauma is trauma, what's the big deal?
Yeah.
But here's where things get interesting. The type of trauma actually gives you, as a nurse, huge clues about what might be happening inside.
Exactly. So like blunt force can lead to things like rib fractures, lung contusions, even a collapsed lung. While penetrating trauma might mean damage to the heart, major blood vessels, a whole other set of concerns.
So knowing the mechanism of injury, was it a high-speed collision or a small stab wound? This helps you anticipate potential complications
Right.
and prioritize your assessment that split-second decision-making can be crucial.
It can, absolutely.
Okay, so let's talk about a condition that might sound a bit dramatic, but is absolutely life-threatening: flail chest.
Okay.
Imagine this: multiple ribs are broken in multiple places,
Oh, yeah.
creating this section of the chest wall that is basically detached.
It's almost like a floating section of ribs.
Oh, wow. Okay, I'm picturing it. That sounds incredibly painful.
It is, and here's where it gets even more interesting. This detached section doesn't move the way it should when the patient breathes.
Oh.
When they inhale, instead of expanding outwards, it sinks inwards, and when they exhale, it bulges out.
Whoa, so it's like instead of working together, the chest wall's working against itself.
Exactly.
And that's got to make breathing really, really difficult.
Really difficult, and that's why flail chest is so serious. It prevents the lungs from expanding properly, which leads to inadequate ventilation and a rapid drop in oxygen levels.
Okay, so you're a nursing student, you're walking into that patient's room. What are the first things going through your mind?
First and foremost, you're thinking ABC's airway breathing circulation.
Right.
Is the airway clear? How's their breathing pattern? Are they using accessory muscles?
Yeah.
What's their oxygen saturation? And then you're thinking about pain management, because breathing with flail chest is incredibly painful.
Oh, yeah, for sure.
And finally, you're thinking about potential complications like respiratory failure. So this patient might need to be intubated and put on a ventilator to help them breathe.
So recognizing flail chest and understanding the severity of the situation is key. You're not just observing. You're anticipating problems and taking action to prevent them. That's what being a nurse is all about.
That's it.
Now let's shift gears to another common chest trauma injury that might seem simple at first but has some important variations. Pneumothorax. Pneumothorax. That just means collapsed lung, right? We learned about that in class.
You're right, but there's more to it than just a simple collapse.
Yeah.
A pneumothorax occurs when air gets into the pleural space, which is the space between the lung and the chest wall.
Okay.
Normally, that space has negative pressure, kind of like a vacuum, which keeps the lung inflated.
Right.
But when air leaks in, that pressure changes and the lung can't expand properly.
Okay, so air where it shouldn't be guided, but you mentioned variations.
Yeah.
What are you talking about here?
So we've got three main types to cover: simple or spontaneous pneumothorax, traumatic pneumothorax, and tension pneumothorax.
A pneumothorax trilogy.
A trilogy, exactly.
Okay, let's break these down.
Sounds good.
Starting with simple or spontaneous. This one sounds like it could just happen out of the blue.
You're exactly right. Spontaneous pneumothorax often occurs in healthy individuals, especially tall, thin men. Think about it. Their lungs are already stretched a bit more because of their body shape.
So their lungs are basically working harder, which makes them more prone to these tiny little air sacs called blebs rupturing.
Precisely. And when those blebs rupture, air leaks into the pleural space boom, spontaneous pneumothorax. It can also be caused by underlying lung diseases like COPD or cystic fibrosis.
So if you're assessing a patient and they suddenly complain of chest pain and shortness of breath and they happen to be a tall, thin guy, spontaneous pneumothorax should definitely be on your radar.
Absolutely. And when you're listening to their lungs, you might hear decreased or absent breath sounds on the affected side.
This is where those assessment skills we've been practicing really come into play. You're not just listening. You're listening for specific things that can clue you into what's going on.
Exactly.
Now let's move on to traumatic pneumothorax. This one's a bit more straightforward. It's caused by an injury to the chest, either blunt or penetrating.
Right.
So that fractured rib from a car accident could puncture the lung, leading to a pneumothorax.
Yeah.
Or a stab wound could create an opening for air to enter the pleural space.
Exactly. And there's one specific sign of traumatic pneumothorax that I remember vividly from my clinical rotations: subcutaneous emphysema.
Subcutaneous emphysema, that sounds intense.
It's actually pretty fascinating. Imagine you're palpating the patient's chest and
Yeah.
you feel this crackling sensation under the skin like bubble wrap.
Oh, wow.
That's air that's escaped from the lungs and is trapped in the tissues. It's a telltale sign that something's not right.
Okay, that's definitely something you wouldn't forget now for the big one. Tension pneumothorax. We know this is a life-threatening situation. What makes it so dangerous?
With tension, pneumothorax air enters the pleural space but can't escape.
Right.
Think of it like a one-way valve.
Uh-huh.
So the pressure in the chest just keeps building and building, compressing the lung, the heart, and even the major blood vessels.
So it's not just a breathing problem. It becomes a circulatory problem, too.
Exactly. That pressure in the chest makes it harder for blood to return to the heart, leading to a drop in blood pressure and eventually circulatory collapse. It's a domino effect.
This is where those rapid assessment skills are crucial. What are the red flags that would make you think that this could be tension pneumothorax?
You're looking for a patient in severe respiratory distress. They're struggling to breathe, using accessory muscles, maybe even gasping for air. Their blood pressure is plummeting. Their heart rate is racing, and their neck veins might be distended.
And if you see those signs, you need to act fast. But what can you do as a nursing student in that situation? We'll get into the specific interventions next time, but I have a feeling needle decompression is going to come up.
You're right. On the money, needle decompression is a life-saving procedure that can relieve the pressure in the chest until a chest tube can be inserted. It's one of those skills that you hope you'll never have to use, but you absolutely need to know how to assist with it.
Okay, so we've covered a lot of ground here. Blunt versus penetrating trauma, flail chest, and the different types of pneumothorax. It's a lot to take in, but we're going to break it down even further in the next part of our deep dive.
Next time, we'll focus on what you as a future nurse can actually do when faced with these situations. We'll cover those crucial assessments, talk about interventions like needle decompression and chest tube management, and emphasize the importance of compassionate care.
Because remember, you're not just treating the trauma, you're treating the person. Stay tuned for part 2.
Can't wait! Welcome back to our chest trauma deep dive for all you future nurses out there. Last time we left off with our pneumothorax cliffhanger.
That's right.
Simple traumatic, then that heart-stopping tension pneumothorax. Are you ready to get into the nitty-gritty of each type?
Absolutely. I feel like we've only scratched the surface.
Yeah.
Let's start with simple pneumothorax, the one that can seemingly come out of nowhere, especially in our tall, thin friends. What's the mechanism behind this one?
Okay, so picture this. You have these tiny little air sacs in your lungs called blebs. Think of them like little balloons lining the surface of your lungs sometimes. For no apparent reason, these blebs can rupture and air leaks into the pleural space.
So it's like one of those balloons popping and letting air escape where it shouldn't be.
Exactly, and that's your spontaneous pneumothorax. Now remember those tall, thin individuals we talked about?
Right.
Their lungs are already stretched a bit more because of their physique.
Right, so those little blebs are under more tension, making them more likely to pop.
It's like blowing up a balloon too much. Eventually it's gonna give.
Right.
Now, spontaneous pneumothorax can also happen due to underlying lung conditions like COPD or cystic fibrosis.
So how would we know if our patient has a simple pneumothorax? What should we be looking and listening for?
Well, the patient might complain of sudden chest pain, often sharp and stabbing and shortness of breath. And when you're auscultating their lungs, you'll likely hear decreased or even absent breath sounds on the affected side.
This is where those clinical assessment skills are so important. You're not just placing the stethoscope on their chest, you're actively listening for those subtle differences in breath sounds.
And don't forget about percussion. You might hear hyperresonance on the affected side, which sounds kind of like tapping on a drum.
Okay, so we've got our assessment down. What about treatment? Is it as simple as patching up a tire?
It depends on the size of the pneumothorax and the patient's symptoms.
Okay.
Sometimes a small pneumothorax can resolve on its own with just observation and supplemental oxygen.
Oh, okay.
Other times it might need a little help.
Help like what?
Well, we might need to aspirate the air with a needle or even insert a chest tube to drain the air and allow the lung to reinflate.
So simple pneumothorax, while serious, can often be managed without too much drama. But let's talk about traumatic pneumothorax, which, as the name suggests, involves some sort of injury.
Right. This is where those blunt and penetrating forces we discussed earlier come back into play.
Right.
A fractured rib that punctures the lung, a stab wound that creates an opening in the chest wall, anything that allows air to enter that pleural space.
And I remember you mentioned a really memorable example, subcutaneous emphysema,
Yes.
the bubble wrap phenomenon.
Yeah. Ah, yes. Imagine you're assessing your patient and you feel this crackling sensation under their skin like popping bubble wrap.
Wow.
That's air that has escaped from the lungs and is trapped in the tissues. It's a sure sign that something's amiss.
So for traumatic pneumothorax treatment would be similar to simple pneumothorax observation, oxygen, possible needle aspiration, or chest tube insertion.
You got it. The goal is always to remove the air, allow the lung to re-expand and give it time to heal.
Okay, now let's talk about the one that makes every nurse's heart skip a tension pneumothorax.
Right.
We know this one is life-threatening, but can we break down exactly why it's so dangerous?
Absolutely. With tension, pneumothorax air is trapped in the pleural space. Remember that one-way valve analogy?
Right.
And the pressure just keeps building and building, but it's not just the lung that gets compressed.
Right.
It's the heart, the great vessels, everything in the chest cavity.
So it's like someone is squeezing the heart and preventing it from doing its job effectively.
You're exactly right. That pressure prevents blood from returning to the heart, leading to a rapid drop in blood pressure and ultimately circulatory collapse.
So this is a situation where minutes matter. What are those critical assessment findings that would scream tension pneumothorax?
You'll see a patient in severe respiratory distress. They're working hard to breathe, using every muscle they can get air in there. Oxygen saturation will be plummeting, and their heart rate will be through the roof.
And their blood pressure will be tanking, right? Because the heart can't pump effectively against that pressure.
Exactly. And you'll likely see a tracheal deviation. The trachea gets pushed away from the affected side because of all that pressure in the chest.
Okay, those are some serious red flags. If you see those signs as a nursing student, what should you do?
First and foremost, call for help.
Right.
Get your preceptor, the charge nurse, anyone who can assist. This is an emergency situation. Then get oxygen on the patient's stat, high flow oxygen via a non-rebreather mask.
So while you're waiting for the doctor, you're supporting the patient's breathing as best you can.
Right, and be prepared for needle decompression as a student. You won't be performing the procedure, but you can assist. Knowing how to set up the equipment, position the patient, and monitor their response is crucial. It's a real-world learning experience you won't forget.
Needle decompression, it sounds so simple, but it can be life-saving in this situation.
Yeah.
It's buying time for the doctor to insert a chest tube, which is the definitive treatment for tension pneumothorax.
Exactly. The chest tube will drain the air and allow the lung to re-expand, and as a nurse, you'll play a key role in managing that chest tube.
What does chest tube management entail?
You'll be monitoring the drainage, how much fluid is coming out, what color is it. You'll be checking for air leaks, making sure the dressing is intact, and documenting everything meticulously. It's a critical nursing responsibility.
I'm starting to see how all those concepts we discussed, the different types of pneumothorax, the mechanisms of injury, all come together when you're actually at the bedside. But it's not just about the technical skills, right?
Absolutely not. It's about the patient as a whole.
Mhm.
Remember, this is a person who's been through a traumatic experience. They're scared. They're in pain. So compassionate care is paramount.
What does compassionate care look like in a chest trauma situation?
It's about taking the time to explain what you're doing, answering their questions honestly, and letting them know that you're there for them. It's about simple things like positioning them comfortably, providing a warm blanket, offering a reassuring touch. These small gestures can make a huge difference in their experience.
It's so easy to get caught up in the procedures and forget about the human element. But as nurses, we need to be both technically skilled and compassionate caregivers.
Exactly. We're treating the whole person, not just the injury.
So we've covered the three main types of pneumothorax: simple, traumatic, and taraxum. Tension, each has its own nuances, but the underlying principle is the same: air, where it shouldn't be causing the lung to collapse. And as nurses, we need to be able to recognize the signs, understand the implications, and take action to support our patients. Now, I know we've thrown a lot of information at you, but don't worry, we're going to bring it all together in the next part of our deep dive. We'll focus on those nursing interventions that can truly make a difference in chest trauma situations, from oxygen therapy and pain management to assisting with procedures like needle decompression and chest tube insertion.
And we'll emphasize the importance of compassionate care, because remember, you're not just treating the injury, you're treating the person. Stay tuned for part 3, where we'll equip you with the knowledge and confidence to handle any chest trauma challenge that comes your way. All right, future nurses, welcome back. We are in the home stretch of our chest trauma deep dive.
Almost there.
We've talked about the types of injuries, the mechanisms behind them,
Huh.
those critical assessment findings, and now
Yeah.
let's get to the part I know you've all been waiting for. What can you, as a nursing student, actually do when faced with a chest trauma situation?
This is where the rubber meets the road,
Yeah.
taking all that knowledge from the classroom and applying it at the bedside.
Right. And let me tell you, in chest trauma, quick thinking and decisive action
Oh, yeah,
can make all the difference.
for sure. So let's paint a picture. You're on your clinical rotation, and a patient is brought in after a car accident.
Okay.
What are those initial assessments that should be running through your mind as you approach the bedside?
First things first, you're always going back to the basics.
Okay.
ABCs,
Right.
airway, breathing, and circulation.
Got it.
Is the airway patent? Is the patient breathing effectively? What's their respiratory rate? Like, are they using accessory muscles?
Okay.
What's their heart rate and blood pressure?
All right. So ABC's always our starting point. We're dealing with chest trauma here.
Yeah.
What are the specific things you'd be looking for in this type of patient?
You want to pay close attention to their breathing pattern.
Okay.
Is the chest rising and falling symmetrically? Is one side lagging behind?
Uh-huh.
And listen carefully to their breath sounds.
Okay.
Are they equal bilaterally, or are you hearing diminished breath sounds, wheezing, or crackles?
So we're listening. What about touch?
Palpation is key.
Okay.
Gently feel along the chest wall. Are there any areas of tenderness, crepitus, that crunching sensation that can indicate a rib fracture?
Right.
And while you're at it, check for tracheal deviation. Is the trachea midline or has it shifted to one side?
Okay.
That's a major red flag for tension pneumothorax.
All right. So we've done our assessment. We've got a patient who's struggling to breathe. Maybe they have tracheal deviation, some absent breath sounds. What do we do next? This is where those nursing interventions come in.
This is where you spring into action. Remember, you're a nursing student. You're not alone.
Right.
You got to let your preceptor or the nurse in charge know what's going on.
Okay.
Communicate clearly and concisely.
Right.
I've got a patient here who's in respiratory distress. I suspect a pneumothorax.
So clear communication is crucial. But while you're waiting for the doctor to arrive, what can you do to help this patient?
First and foremost, get that patient oxygen. High-flow oxygen via a non-rebreather mask is your go-to until further interventions can be done. You're trying to maximize their oxygen intake and support their breathing as much as possible.
Oxygen, always a good idea.
Yeah.
When someone's struggling to breathe. What else can we do while we're waiting for the doctor? What about pain management?
Oh, yeah.
I imagine breathing with a fractured rib or a collapsed lung
Right.
is incredibly painful.
You're absolutely right. Pain management is essential. Remember, pain can actually worsen respiratory distress because the patient is hesitant to take deep breaths.
Right?
So advocate for your patient, let the doctor know they're in pain and need something to help manage it.
So we're supporting their breathing with oxygen, managing their pain. What are those specific interventions we talked about, like needle decompression?
If you suspect a tension pneumothorax and the patient is showing those classic signs, tracheal deviation, absent breath sounds, low blood pressure, the whole 9 yards, be prepared to assist with needle decompression now as a nursing student. You won't be performing this procedure,
Right.
but being involved is invaluable experience.
What kind of things would you be doing to assist?
You'll be helping to gather the necessary equipment, positioning the patient, monitoring their vital signs throughout the procedure. It's a chance to see those textbook concepts come to life
Yeah.
and understand the urgency of the situation.
Talk about a real-world learning experience.
Right,
But needle decompression is just a temporary fix.
right. It's buying time until the doctor can insert a chest tube,
Right.
which is the definitive treatment for most types of pneumothorax.
Gotcha.
As a nurse, you'll play a key role in managing that chest tube.
What does chest tube management entail?
You'll be monitoring the drainage,
Okay.
how much fluid is coming out, what color is it. You'll be checking for air leaks, making sure the dressing is intact, and documenting everything meticulously. It's a critical nursing responsibility.
I'm starting to see how all those concepts we discussed, the different types of pneumothorax, the mechanisms of injury all come together when you're actually at the bedside.
Yeah.
But it's not just about the technical skills, right?
Absolutely not. It's about the patient as a whole.
Right.
Remember, this is a person who's been through a traumatic experience. They're scared, they're in pain, so compassionate care is paramount.
What does compassionate care look like in a chest trauma situation?
It's about taking the time to explain what you're doing, answering their questions honestly and letting them know that you're there for them.
Yeah.
It's about simple things like positioning them comfortably, providing a warm blanket, offering a reassuring touch. These small gestures can make a huge difference in their experience.
It's so easy to get caught up in the procedures and forget about the human element.
Hmm.
But as nurses, we need to be both technically skilled and compassionate caregivers.
Exactly. We're treating the whole person, not just the injury.
Wow, we've covered so much ground in this deep dive. From the initial shock of seeing a chest trauma patient to those crucial assessments, the life-saving interventions, and the importance of compassionate care.
It is a lot, but here's the key takeaway for all you future nurses out there.
Okay.
Chest trauma is serious business. But with the right knowledge, quick thinking, and a whole lot of heart,
Yeah.
you can make a real difference in your patients' lives.
This deep dive has been incredibly informative, empowering, and maybe even a little bit inspiring. Remember, nursing school is tough, but you're learning the skills and knowledge to handle these challenging situations, and you're developing that critical thinking that will set you apart as a nurse.
Keep learning, keep practicing, and never be afraid to ask questions because at the end of the day, it's all about providing the best possible care for your patients.
And on that note, we'll wrap up our chest trauma deep dive. We hope you found this episode helpful as you embark on your nursing journey. Until next time, stay curious, stay compassionate, and keep on diving deep.